Tonight's program is entitled Halting Cell Hijackers, Battling for Better Cancer Prevention and Treatment. My name is Amy Deshler, and I'm an Assistant Vice President in Duke Development, and I have the very good pleasure of raising money for the Duke Cancer Institute and for the Duke Children's Program. Excited to have you here with us tonight. Our program is part of our theme, as you can see, Fortifying the Body and the Brain. We have some wonderful speakers that are joining us tonight. They're experts in their field and world-renowned in their research, and I know you're going to enjoy hearing from them. Steve will be moderating our session, and he is the Deputy Director for the Duke Cancer Institute. He's also Professor of Medicine and Professor of Pharmacology and Cancer Biology within the School of Medicine. So without further ado, I am going to turn it over to Dr. Steve Patierno.
Great. Well, thank you, Amy, for getting us started. I'm very excited to be here with you tonight. Tonight, I'm going to be moderating a panel discussion. The two speakers are Dr. Sandeep Dave, who is our Wellcome Distinguished Professor of Medicine in the School of Medicine, and Dr. Shelley Hwang, the Mary and Deryl Hart Distinguished Professor of Surgical Oncology and Radiology in the School of Medicine. Their bios are available online. We're not going to read through them because they are both so decorated and experienced, it would take up half of our evening just to give them the proper credit. So please do look up their bios at the end. Our theme tonight is Halting Cell Hijackers. It's an interesting title, and I think that title was chosen because one of the many things that goes wrong at the earliest stages of cancer, and as cancer progresses from its earliest stages to becoming the most lethal forms of cancer, which are what we call metastatic cancer. What happens during the progression of cancer is that the normal molecular machinery that runs how our cells operate, how our cells communicate with each other, how our cells function within our body gets disrupted. In a way, we can think of it as that machinery gets hijacked by genes that have gone awry, sometimes through mutations, sometimes through epigenetic mechanisms, sometimes through things that affect gene expression, what we call transcriptomics. But during that hijacking, as I mentioned, occurs at the earliest stages of the formation of cancer, and it becomes like a runaway freight train as cancer progresses. So tonight we're going to be exploring what that means in terms of that molecular hijacking from the earliest stages of cancer to the most lethal stages of cancer. And we're going to talk about it in the context of what is called precision oncology. And we have two absolute experts with us with vast experience in precision oncology, but not only during the treatment phase. The word precision oncology now applies to the entire continuum of cancer research, of cancer care, from early detection, screening and early detection, to something called interception, which you're going to hear about tonight. It's a new topic that Duke is helping to lead the way on, to treatment, and then extending into survivorship. Dr. Hwang, would you start off and give us a few sentences about your research?
Yeah, I'd be happy to. And I wanted to welcome all of you tonight. It's really exciting to be here with some good friends to talk about science and kind of peel back all the really exciting new developments that are happening in cancer research right now. So I'm a surgical oncologist and I'm a breast cancer specialist. And for my entire career, I've been really interested in the shades of gray, the gradients between normal and cancer. And because of that, I've gotten very interested in an entity that precedes the development of cancer and got really interested in this field of cancer interception, which is to try to identify these abnormal cells at the very beginning of undergoing malignant transformation. So trying to understand what causes those sorts of changes, how we diagnose them, what we do when we find them, as a window to preventing cancer is something that I've been really excited about. And I think we have a lot of new tools now that are really helping us to look at prevention in a completely new way. Those are some of the things that I like to think about. Our lab is very focused on trying to develop molecular markers to determine who's likely to develop a bad cancer versus those that are likely to have a more indolent course of disease. And I think understanding that a little bit better, the trajectory of the disease based on what cancers look like at the time of diagnosis is something that I think will help us to personalize treatment rather than treating everyone as if they had the same disease, because of course there are as many different kinds of cancers as there are people who develop them. And it's really the interaction between the host environment and the cancer cells themselves, and then the immune system, which is kind of underscoring everything, that determines the trajectory of a cancer.
Thank you, Dr. Hwang. Sandeep, can you take a few moments to describe the nature of your research and your work, please?
Yeah. So I took kind of an unconventional path to medicine. I was an engineering and computer science major before I went to medical school, which seemed like kind of a irrelevant thing for a very long time. And then as the genomic revolution unfolded, it became kind of a very fortuitous mix of timing and opportunity, because the genomic revolution has been driven largely in part by the computing revolution. And what that has allowed us to do is to explore in detail how different cancers are different from each other at the molecular level and how they're similar to each other. And that has allowed me and colleagues like Shelley and Stephen and a whole branch of cancer biology to better define cancers and how they exist at the molecular level. And that has been kind of ongoing work for the past decade that many of us have been engaged in. Most recently, we've become interested in the question of how do we bring these technologies to transform cancer care. And as Steve mentioned, there are many kind of different aspects to cancer care, right from detection, perhaps early detection, to diagnosis, to different interventions, including treatment. And the part that we are focused on currently is the diagnosis end, which is how do you bring the genomic technologies to the fore in terms of improving the diagnosis of cancer. Now, the lifetime risk of us developing cancer is something to the order of 1 in 3 or perhaps even 1 in 2, right? And so the odds of cancer affecting us or a loved one in our lives is almost 100%, right? And that journey of a cancer patient often begins with a biopsy when they have a mass or perhaps something seen on a mammogram or a colonoscopy that then needs to be subjected to a whole battery of tests before you can figure out what cancer they have, and no treatment can begin until that diagnosis is established. For most patients, that is an incredibly nerve-wracking time of their lives. So from the time to biopsy to getting a diagnosis of cancer, particularly blood cancers where I work, can be something like 2 to 3 weeks, which are among the most excruciating weeks of that patient's life, right? Because until they know what they have, if they have cancer, what kind of cancer, and so on, nothing can happen. And the reason it takes 2 to 3 weeks and almost $10,000 to $15,000 is that piece of tissue that is called a biopsy has to be subjected to a whole battery of different tests, which are usually done sequentially to save tissue and to save money. And a pathologist is directing those tests. And the question we asked is, can we use genomics to do all of those tests in one fell swoop, and greatly shorten the time of diagnosis from the current standard of 2 to 3 weeks to even a couple of days. And that has to happen by marrying genomic technology with computing technology and machine learning, where you have algorithms that enable you to discern what the patient's tumor is made up of, and also allows you to incorporate a lot of conventional testing. So even things like immunohistochemistry and flow cytometry, and don't worry if these terms are not familiar to you. They're very standard, widely used tests, and all of them can be rendered in genomics and may serve to completely replace them. And so that's the work we're involved in. And a special interest of ours is also kind of trying to make this available globally. And so, as many of you know, Duke has a site in, we work closely with in Tanzania. And we help provide the care there. And I was fortunate to visit with a small group a few years ago. And all the problems I described about getting a diagnosis and how long it takes, and sometimes it can still be inaccurate, are magnified, almost a millionfold in Tanzania. Because even those resources for doing that battery of tests don't exist. Oftentimes patients are treated for cancers they don't have or not treated at all. And so everything that is a problem here is magnified greatly in Tanzania. And so our hope is to leapfrog over kind of this lack of resources using genomic technologies, which are really the state of the art, both in the United States and Tanzania, to improve the diagnosis of these patients and bring them to treatment sooner. And then lastly, I should point out that Tanzania is not just a distant country. Oftentimes the issues we deal with in Tanzania and globally exist right here at home for many of us, where access to care is uneven, access to accurate diagnosis is uneven. And our hope is to use genomics to level that playing field and improve care for everyone.
Dr. Hwang, you mentioned, and I also mentioned the term interception. It's one of the hottest topics in cancer research right now and in the practice of oncology, still in its earliest stages. It's focused on detecting cancers earlier and earlier, using more sophisticated, hopefully less invasive techniques, and then trying to intervene earlier. Could you expound on that in the context of the groundbreaking research that your laboratory has conducted on early stage breast cancer and the decision-making about whether to treat or not treat?
Yeah, Steve. So I agree with you. One of the most exciting areas in cancer research right now is trying to understand how to detect cancers earlier, but not too early. And I think this has really come to the fore now with a lot of early cancer detection methods that use just a simple blood draw. So you may have heard of a company called Grail, for instance, and there are many others that are just popping up like mushrooms that take a very simple blood test, and they're able to look at either the genes or some characteristics of the genes in the blood and be able to determine whether you're at risk for having a cancer develop within the next few years. So what these gene tests are doing is trying to identify genes that we know are coming directly from the cancer and circulating in the body. So if you take a really big step back, there are about 37 trillion cells, and many of those cells aren't even human cells. They're cells that belong to the bacteria that we live together with, and that's a biome issue. It's a whole nother very fascinating area of cancer research right now. But when we look at the fact that there are 37 or so trillion cells in the body, cells are constantly undergoing genomic changes or dividing in an abnormal fashion, and some of those cells get shed into the circulating environment. And so the idea is to use these ultra-sensitive detection methods to try to pull out those cells that have the characteristics of cancer cells. The problem is that if you are testing a very large population of patients who have kind of normal risk, then you can go through tens of thousands of patients before you identify patients who have this risk for cancer. And so I think we have to be a little bit more careful about how we choose the patients who we test in this way. But if we do that, the hit rate for just a normal low risk population is probably something like 1%, where we can start detecting cancer cells. That doesn't mean that 1% of patients has cancer. About half of those will have a cancer that we can detect. So if we scan these patients because of a positive blood test, we can find that there actually was a cancer that was completely undetected. And so that fosters early cancer detection and better and more effective treatments for that patient. So that's clearly a win. But this other group of patients, so half the patients who have a positive blood test don't have anything detectable with the usual imaging methods that we have. And so these patients are kind of stuck in this gray zone where they don't really know whether they have cancer or not, and they're undergoing monitoring constantly. So I think those patients present the opportunity. If we can identify which patients are at greatest risk to have cancer in the near future, but we are able to come up with strategies to prevent those cancer cells from moving to the next step, then I think that's really a game changer in terms of cancer prevention. So instead of giving treatments or different therapies to everybody who's at potential risk for the disease, what you have is a more concentrated group of people who we know are at tremendously increased risk, and we can focus our monitoring, our prevention. Those are the things that we can concentrate in patients who we know to be at greatest risk. So, I mean, that really opens the door up for a whole new way of thinking about prevention, not on so much a population basis, although I think that's the next place that we need to go, but to try to identify people who are at greatest risk and really focusing our prevention strategies on that population.
Very exciting time in cancer research. Dr. Dave, your laboratory sequenced the DNA of one of the largest cohorts on the planet of a form of lymphoma, and that included patients from other parts around the globe as well. And you found some remarkable differences and a remarkable spectrum of gene mutations in that cohort. Could you say something about how you see that kind of work applying to practical decision-making, what's called precision oncology, and the application of novel therapies?
Yeah, so there's two aspects to this work. One is understanding what are some of these mutations that collectively add up to cancer. And having these large cohorts of patients allows us to understand the full spectrum of what drives some of these cancers. And the good news for some of these patients is that we already know some treatments that can be coupled to these mutations. So there are existing therapies that have been developed for certain mutations where just the existence of the mutation is a strong clue of kind of what treatment to use. And that provides a starting point for treating those patients. The other aspect, I think, is going to be the more lasting contribution, which is allowing us to understand these building blocks of cancer in a way that allows us to understand their deeper biology and go after that deeper biology that gets us to new treatments. And that deeper biology is already allowing us to understand some aspects of cancer that we did not know before. So Steve mentioned that we worked in this form of lymphoma. And what we found is that when we look at African Americans who have a much higher risk of this kind of lymphoma and develop the disease at an age that is usually 10 years younger than Caucasians, that they have a very different set of mutations. And what that means is that we've been going about diagnosing and treating these patients, entirely incorrectly, based on the assumption that everyone basically got the same spectrum of disease. But as it turns out, our disease models, that even when we develop mouse models, they don't fully incorporate the specific mutations that occur in African Americans. And then the treatment approaches that we have, we know are failing African Americans because they tend to do less well with the existing therapy that cures as many as 60 to 65% of Caucasians. Roughly half of that happens in African Americans. And so understanding the biology, I think, is key in the end to trying to understand how we can intervene at different steps and what the best interventions would be.
Thanks Thanks, Sandeep. You actually, without without even trying, brought in to the discussion a really important part of oncology right now, and I know this is something that both Dr. Hwang and you share with me as a passion in the application of our research, and that is this issue called cancer disparities, or the unequal burden of cancer among minoritized or marginalized populations, and how that affects their trajectory, their journey through cancer. So, Dr. Hwang, I would love, something that you and I talk about all the time. So I would love to give you an opportunity to just share your heart on that, and how you see the current revolution in precision oncology impacting our desire to move from cancer disparities towards achieving what I call cancer health equity.
Yeah. And Steve, thank you for that question. And I think you are really leading the field here and teaching us what we need to understand better and how we need to care better for our patients, regardless of race, ethnicity, and background. But I think coupled with that is our need to understand the biology behind what is causing some of these disparities in outcome. So, for many, many years, we thought that the difference in outcome between Caucasian populations and African American populations could really be attributed to the fact that there are some groups of patients, we all know this, who have very poor access to healthcare. And I think the United States really has a big moral burden, because we know that this disparity occurs. And we still haven't been able to do much about it. And that's always been kind of at the core of what I think a lot of us have assumed, that if we could just fix the access problem, then that would level the playing field. But really the amazing finding that has become more and more apparent is that even if we correct for the access issue, and we are able to get more people in to get appropriate healthcare, there's still really important discrepancies in not only the kinds of cancers that people get if they have a different racial background, but the outcomes of the cancers are really different, despite the fact that they get the same treatment. So I think that just shows us that there's a lot more work that we need to do about understanding which sorts of biologic pathways are the dominant driving forces in patients of one race or ethnicity compared to another. And I think just understanding that better is likely to uncover new targeted therapies that will be most appropriate for certain patients of a certain background or race ethnicity, and others that will be more appropriate for patients who are from other backgrounds. And I think this points to one of the really big causes of disparity currently in cancer research, which is that most patients who participated in clinical trials, and that's, many of you know, that's the foundation of how we make progress in cancer. But most of those patients who've enrolled have come from very advantaged and white backgrounds. And so those are the patients we understand the most about, and we don't really understand the effect of our treatments, especially novel therapeutics, on patients who come from a very different kind of background. The good news is that I think we have all understood the moral imperative to try to rectify these sorts of disparities. And I think with people like Steve, we have investigators at the DCI. Kanamiju is really a pioneer in this area. And we're just surrounded by people who are excited about understanding these racial or these biologic sources of disparity, and hoping that by understanding the driving forces better, then we can intervene in a more personalized and individualized way.
Dr. Dave, any other comments on that particular topic?
No, I completely agree. And Steve and Shelley have been leaders in kind of driving this charge throughout the DCI, which has really energized a lot of investigators around this really important problem.
So let me ask maybe a slightly more upbeat question. I know when we sometimes when we're talking about oncology, we sometimes focus on, how steep the challenge is and how difficult it is. But there's been a revolution in the last 10 years. And there are so many cancers that even a few years ago, the diagnosis was essentially a death sentence. In other words, the incidence rate and the mortality rate within 18 months were nearly identical. But now we are seeing a large number of cancers that with new therapies, particularly immunotherapies right now, and more on the horizon, where survival is jumping in leaps and bounds. So much so that the advances in treatment of one cancer, lung cancer, a few years ago, actually changed the overall survival rate across the entire nation to cancer. It went down simply because of improved survival in the treatment of lung cancer. So let me ask the two of you, what excites you most right now about what's going on in cancer research? What kind of groundbreaking research has lit a fire under you even more than what would have been there when you started your career?
I can start off, Steve. I think you've mentioned one of the things that we're all very excited about and hopeful about in cancer treatment, and that is trying to harness your immune system to help fight cancer cells. And I think the way that we've always conceived of it is that the immune system has always been responsible for just constant surveillance of identifying these malignant transformations in the cells in our body. And by and large, a huge proportion of the cells that are abnormal and could potentially develop into cancer get picked up and taken out by the immune system, so preventing cancer. But as the body ages and as more of these cells become abnormal, and as the immune system changes over the lifespan, there have been, and we know that this happens, there are cells that evade the immune system. They hide from the immune system. They escape this kind of immune surveillance. And so what's super exciting to me is that we could start training the immune system to be more effective and to capture those cells that were evading the immune system before, which is very, very relevant to the testing that I was telling you about earlier, where we can start detecting the earliest types of changes in the blood and trying to design a therapy to activate the immune system again against those cells. And now, we can detect those cells in the blood, so we know what the targets are. We're all very, very familiar with vaccines now. I think if we learned nothing during COVID, it's that vaccines can be incredibly powerful. And what excites me the most in this interception space is that if we could identify the kinds of targets that we need to identify vaccines for, because we can detect them in the blood, and they're that, half those patients who have an abnormality in the blood but don't have anything detectable on imaging, those are going to be the patients that I really believe we can design vaccines for, and that's going to be the new preventive approach. And I think that's tremendously exciting. There's a lot of work we need to do in that regard. There's so much that we don't know, but I think just the hope that brings about for a brand new way of preventing cancer is just super exciting.
Dr. Dave, same question. What excites you the most? And if I could I get you to expound also a little on an area that you're an expert in, and that is single cell sequencing?
Yeah, so I think what excites me most is that we now, have been using some of these cutting edge technologies for some time, and it is finally, we are starting to see that transition of that technology being used for discoveries to actual patient care. And that is a huge motivator for many of us. I remember when I was a postdoc and I published this paper in the New England Journal of Medicine, and I was very excited and very pleased with the outcome. And it took me years to realize that even though this was a paper widely cited and widely accepted, that it was actually a failure in the one metric that mattered, which is, translating it to patients, right? So people accepted that this is a better way to diagnose patients, yet nobody took that critical step to actually implement it for patients, because those steps are actually quite daunting and require very large investments of time and money. And again, the advent of new technologies has kind of democratized that playing field to the point where now, increasingly, the same technologies that are used for discovery can also be used for patient care. That means what is published in a major journal today can be immediately be made available theoretically to patients. And there are many such kind of secondary technologies. So single cell sequencing is one that Steve mentioned, which allows us now to understand not just the role of the tumor, but the entire, of the malignant cells in the tumor, but also the microenvironment. And so there's actually a very easy way to kill cancer cells, which is you just take them out of the body and separate them from the normal cells that surround them. And the vast majority of cancer cells cannot survive without those without a supporting cast of normal cells. And very little is understood about what those normal cells are or how their interactions exist with cancer cells. And we now have better tools than ever to kind of start understanding that critical nexus. And so this is kind of simultaneously an age of discovery and clinical translation, which makes it a particularly exciting time to be alive and to be engaged in this work.
And Sandeep, if I could just add on to what you were saying, I think the really amazing thing that we're discovering with some of the technologies that you mentioned is that instead of just grinding up the entire tumor and trying to figure out what genes are in there, what we can now do is just look to see how the cells are individually organized with respect to each other. That kind of spatially resolved technology is what we call it. And just understanding how the cells are organized helps us to understand what the interactions are between the cells, and how we could develop other ideas about how to intervene in those interactions or promote those interactions if they're good ones. And then start understanding a little bit more about what the proximal neighborhood of a tumor cell is or a tumor is, and how the components in a cell neighborhood help to determine whether patients are likely to do well or poorly from their cancer, or are likely or not likely to respond to certain treatments. So I think this ability to spatially resolve some of this molecular data that we're identifying really takes our investigations to a whole different place.
Yeah, I agree.
So there's an old metaphor that's overused it's a sports metaphor about skating to where the puck is going to be. Or if you're a soccer player, good soccer players don't spend their time chasing the ball. They have a second sense about where the ball's going to be, and they're there to get it ahead of everybody else. So this is a question. It's a little blindsiding both of you. We know that we're in a maximal trajectory of immunotherapy right now. We're in the age of immunotherapy. But as always is the case, immunotherapy will continue to be transformative. It'll continue to grow. But over a course of years, let's say on a 5 to 7 year horizon, like most other therapies, it will reach an asymptote. New immunotherapies will come on, older ones will drop out, but it'll level off. If you had to speculate where you think the puck is going to be on the other side of the immunotherapy revolution, any thoughts about that?
Well, Steve, I think that's easy because I've mentioned it before. I mean, it's one thing to treat a patient who already has a cancer and to try to come up with the best therapies that we can, but I really would argue that that's too late. And if we can start intervening much earlier upstream from where we are able to detect cancer now, I mean, there's no question that patients are going to have better outcomes. So I think harnessing the immune system, using vaccines or other sorts of immune-based therapies, I think that's where the puck's going to be. I think that's where the excitement is starting. We have a lot to understand about what that space looks like, but I think it is about the most exciting thing that's happened in cancer prevention that I know of, certainly.
Sandeep?
Yeah, I view some of these revolution as kind of unsatisfying, right? So the immunotherapy is clearly an advance in cancer care, yet only something like 20% of patients derive lasting benefit. Now, for them, it's a really critical intervention, and same thing with cellular therapies, with CAR T cells and so on. I think there's something like a third to 40% of patients who have long-term benefit from these expensive therapies. And we don't really know how to distinguish those patients who benefit from this $500,000 therapy versus those who don't, and in some cases suffer severe side effects and even death. I think the critical need, so I agree with everything Shelley said. I think there's another dimension that needs to evolve with this, which is the field of modeling these cancers in a more faithful way. And currently, a lot of what we do with cancer therapy development is often kind of flying blind. So we have some good ideas, and then bringing them to fruition takes a very long time because we don't have good, faithful ways of representing what those tumors are like and how to approach them in real living humans. And so a lot of time is wasted in mouse models that don't truly resemble human patients, and in other models that have other limitations. And we now know what we need to model. And I think there is an equally big revolution waiting to happen in how we model these so that we can connect patients to therapies more effectively and avoid this kind of central issue, which is oftentimes only a minority of patients respond to any given therapy, and we often end up wasting a lot of time. Often the last months of their lives are spent getting futile therapy, and of course this is all very expensive to the healthcare system as a whole.
And Sandeep, I think what you're I think alluding to is that we have the capability. Or I can see that we're going in a direction where cancer is going to be a chronic condition rather than a lethal one.
Yeah, for many patients already.
Yes. And I think that really is another trajectory that I think is quite exciting and gives a lot of promise to patients who are, if they do develop cancer, and as Steve mentioned, 1 in 3 or maybe Sandeep, it was you, but 1 in 3 patients, and 1 in 3 of us on this call will develop cancer. And the idea is for that to be a chronic condition that we can treat like hypertension or diabetes, rather than for that to be a universally fatal sort of situation.
Yes, absolutely. We long for the day when we can detect cancer early and use interventions that are non-cytotoxic, where we don't need radiation, we don't need chemotherapy, we don't even need surgery. We have a pill that's not toxic, and it very specifically shuts down the growth of that tumor cell and prevents it from progressing any further. Yes, that's what we long for. Well, thank you so much for that open discussion. I want now to, we're going to turn to the chat and open it up to our listeners.
Yeah, there have been a few questions in the chat about detection of cancer cells in people who've already developed and been treated for cancer. I think that's a really excellent question, and a lot of the development of these technologies. And don't get me wrong, this is a very nascent field. I mean, it's just starting to get off the ground, so there's plenty we don't know about what the accuracy of these tests are. Who should be tested, how often we should be tested, which test is the best. But there have now been some early clinical trials that show that patients, when they recur, have these circulating cells in their bloodstream so they can be detected. And patients who are responding to a particular treatment have a reduction in this number of circulating cells. So, I mean, they act in the way that you would expect them to act. We haven't had the ability to follow patients like this in the past. So we've always really relied on patients who've had cancer to start getting symptoms from recurrent disease for us to even get, clued into the fact that there could be a cancer recurrence. But I think this sort of technology, this sort of monitoring technology could really help us to determine whether in patients who develop metastatic disease, it might be helpful to intervene way before they get symptoms. And that is a brand new world that we don't really know how to play in that world yet because we haven't had that. But I think that's another area that this sort of technology will help us to explore.
There is a follow-on question in the chat also about screening and precancerous markers and the issue of avoiding false positives.
Okay, now this is a subject that I could spend the next 3 hours talking about, but to make it brief, there are some diagnoses, some conditions, which we currently call cancers or precancers. And if you, and we know now that most of those patients will not go on to develop a full-blown cancer. So for those patients who never would go on to develop cancer, all the treatment that we're giving them is just toxicity and without benefit. So my research really focuses on trying to identify those patients who really do need surgery and treatment, and those who we can just monitor closely using some of these technologies we've talked about today. But I think that is, that's going to be where we need to go, because as we do more of these very early screening technologies, this person is absolutely right. We're going to be squarely in that place where we have false positives, we have false negatives, and we are going to be grappling with this as a society about how to deal with these test results. So a lot we don't know, but I think really important questions.
Sandeep, you have been at the forefront of analyzing DNA mutations as diagnostic tools, prognostic tools, theranostic tools that could predict for therapies. One of the questions that came out in the early days is, what if we find these similar mutations in normal tissue? And what if we find mutations in, let's say, blood cells of patients who don't have cancer, but we discover they're carrying a mutation that might predispose them to cancer? What are the practical implications of that, including one of the questions in the chat, does it impact insurance companies? And could it negatively impact an insurance company's desire to pay for therapy, or maybe even drop the patient because they're predisposed to cancer? And that actually, I'll open it up to both of you, but Sandeep, why don't you start?
Yeah, I think Shelley was alluding to a lot of these issues already. So we know that a lot of cancers arise from kind of pre-existing, kind of pre-malignant conditions. And so so chronic lymphocytic leukemia is the most prevalent leukemia in America. And 100% of those patients have a pre-malignant condition called monoclonal B-cell lymphocytosis, which is kind of a mouthful. So 100% of patients with this leukemia have that pre-malignant condition prior to that. But so 100% of these leukemias arise from this condition, but the reverse is not true. So if you take patients over the age of 65, something like 5% of patients will have this monoclonal B-cell lymphocytosis, the pre-malignant condition. Of those patients, fewer than 10%, I think actually the number is fewer than 5%, will actually develop any kind of malignancy. Right? So you have a huge disconnect between what we consider to be a pre-malignant condition and the actual risk of developing cancer. And I think that is an important frontier, just as Shelley was talking about, in understanding which of these patients should be left alone, frankly. We should not be subjecting them to, a lifetime of anxiety of kind of developing cancer, next year or next month or whenever it might be, because their risk is actually no different than, if they hadn't been diagnosed with this. So how, as physicians, how have we done them a service by giving them this condition that makes them more anxious, yet does not improve their risk of, early mortality? And so this remains an open question because there's a lot we don't know. And this requires careful longitudinal trials of the very kind that Shelley has been a leader in developing, that look at the behavior of these tumors and their effects in patients over a lifetime, and looking at kind of a combination of modalities for testing and how you intervene in these patients. So there's not an easy answer. And my fear is exactly what Shelley was alluding, which is that we get better and better at picking up what we consider to be precancerous mutations in patients. And the majority of these patients may or may not develop cancer in their lifetimes. And we need better tools to understand who those patients are at risk, because telling somebody that, hey, you may or may not have cancer is not a nice thing to do, right? I mean, it's a terrible thing to do if they don't actually have cancer. We can't really counsel them. We run up, the radiation incurred by a lifetime of CT scans might give them cancer if you're not careful. So there are real risks to this. There are some legal protections against genetic discrimination. But again, I don't think, insurance companies have fully kind of figured out how to deal with a lifetime of testing for some of these patients. And we know what their inclinations are. Their inclinations are always to kind of reduce costs, and that would mean that we have inadequate ways of monitoring these patients, and that too needs to be understood.
If I had to say that there could be an aha moment from this conference, I would say that I think many of us feel like you either have disease or you don't have disease. You either have the cancer or you don't have the cancer. But I think hopefully this conversation has kind of opened your mind to the fact that cancer is not a binary. And it's a spectrum of disease, and at some point that spectrum gets detected by whatever diagnostic test that we're using. I think just as there is a spectrum in kind of the progression pathway, there's a spectrum in terms of the kinds of cancers that you can get, some that are just so indolent that nobody would ever die of it, even though we call it cancer, and others that progress so quickly that they become metastatic between 2 mammograms. So I think that sophistication of understanding that it's not just a binary situation is what I would really love the public to start understanding and thinking about. Because when we think of it as a non-binary condition, then I don't think it becomes as easy to become frightened of it, because there's a big spectrum of disease out there, and we put it all in one bucket and we call it cancer. But I think that's way too simplistic. And I think everybody is starting to catch on to this idea of how there are different spectrums of all sorts of diseases, including cancer.
So there is a question in the chat that is actually very specific about, are there ways to determine who will or will not respond to immunotherapies like CAR T? But let me just reframe the question a little, because, even when I was in grad school, and I won't tell you how many decades that was ago, and as a postdoc, in the very, very earliest stages of immunotherapy, back when Steve Rosenberg at the NCI was the only person running these trials on 10 people with a immunological intervention, and he would get an extraordinary response, but in only 2 people out of 10, and no one else responded. And now we dial the clock forward, and we're in the middle of the immuno-oncology revolution and CAR T cells, and we're actually still seeing the same thing. There is a subset of patients who respond dramatically. The tumor melts away, and there are other patients who don't seem to respond at all. and which is quite extraordinary when you consider one course of CAR T therapy is about $500,000, actually a little bit more than that. So I wonder, just as a last question for both of you, if you might just speak to this issue about the importance of individually tailored precision oncology so we can get at this question of who's going to respond to therapy and who's not going to respond to therapy.
Sandeep, maybe I can punt that to you because this isn't an area that I work in day to day. But I mean, the only thing that I can say is that there are different biomarkers we're looking at in tumors to determine whether, certain tumors might respond to immunotherapy or not. I think there will also be additional markers that we can look at in the circulating compartment, but I think specific ones I'm not very aware of. I'm not sure that they exist, actually.
Well, it's actually even more general question, Shelley, just, this issue of extraordinary responders versus non-responders, regardless of what the modality of treatment is. And is there something that we can learn from either one of those groups that might help us understand how to tailor our treatments more specifically?
In the last 3 minutes, the answer is definitely yes. I think, about 20 years ago, we started treating some cancers with chemotherapy before surgery, kind of changing the order of how we give our treatments. And I think that sort of just a subtle change in how we order our treatments has really given us the ability to learn a lot more about which cancers are exceptional responders to certain treatments versus not. I don't know whether that's a possibility in the CAR T cell world, but one huge advance is to be able to give these treatments while patients still have the cancer rather than to remove it first and then try to figure out whether patients are actually responding or not.
Sandeep, last word?
Yeah, I think we still have a lot to learn. And so when we've looked at exceptional responders, for example, in different trials and different therapies, the answers are often not as clear-cut and satisfying as we would like. And so even when we've done a lot of workup genomically and so on, we can identify, only something like a clue to the response in these patients at 20 or 30% of the time. Right, and this is in a very selected group of patients. Exceptional responses themselves are rare in many of these therapies. And so I think this is a time to measure, right? And so in every clinical trial that does not use, genomic and other technologies to fully understand the molecular makeup of tumors is an opportunity lost, because every trial is going to have responders and non-responders, and we have better tools than ever to measure the makeup of these tumors. And so I think it behooves us to measure, and it behooves us to stay humble, because there is a lot we don't know. And the only way we will learn is by kind of doing these studies systematically in every patient we can possibly enroll across the entire kind of spectrum of disease in terms of the cancers themselves, and also who gets the cancers in terms of equity and access to care.
Well, thank you both for this great discussion. I'm going to turn it back over to Amy Deshler. I did want to just quickly say, Mr. Carson Smith, I appreciate the last two questions that you put in the chat. These are complex questions that can't get just easy, quick, pat answers. So I would be happy to discuss those questions with you personally. It's an area I've spent 25 years of my life working in. And if you want to look me up at the Duke Cancer Institute website, I'd be happy to chat with you about that. So I'm going to close it here and turn it back over to Amy Deshler.
Great. Thank you so much. I really like to thank everybody for being with us tonight. I find it truly remarkable the Duke Cancer Institute is celebrating our 50th anniversary, and the advances in cancer research and clinical treatment are profound, and I look forward to seeing where we're going to be in the future. It is an honor and a privilege to work with the Duke Cancer Institute. As has been mentioned many times, and as we all know, there's no one immune from being touched by cancer, whether it's 1 in 3 of us or those that we love. And so there's nothing more important than the work that's being done here.